It's good morning or good afternoon. It's 12 noon. So I'm here today to talk to you about alcohol-related liver diseases from binge to cirrhosis. I hope to cover these topics during the course of my lecture. Liver diseases due to alcohol previously were called alcoholic cirrhosis or alcoholic hepatitis. But due to the stigma associated with the word alcoholic, now it's used as alcohol-related or alcohol-associated mainly. So it's one of the oldest and most common cause of advanced liver diseases in the world because fermented beverages were available since 10,000 BC. It's one of the leading cause of liver-related mortality in United States, and it takes more than 40% of listings for liver transplantation in US. It causes 3 million deaths annually worldwide, about 6%, which exceeds the deaths due to hypertension and diabetes combined. COVID-19 pandemic has affected alcohol use disorders as well as liver disease quite badly. Alcohol use has risen by 14% and alcohol use disorder-related mortality has increased by 24%. Unfortunately, mortality due to alcohol-related cirrhosis and alcohol-related hepatitis has increased, especially in the young and in the females. 4 to 5% of US population meet the criteria for alcohol abuse and or dependence. Sri Lanka is not so different. Even though we don't have national data, there is a study done from 2007 to 2014 in Ragama using semi-urban population, which found out unsafe alcohol use in 9.1%. And among those unsafe alcohol users, the prevalence of alcoholic fatty liver was 31% and the annual incidence was 7%. Is there a safe limit of alcohol? I would like to say no, because alcohol is a carcinogen and there's no threshold for the risk of cancer. But for the general population, up to 2 drinks a day for males and 1 drink a day for females can be considered safe. 1 drink would normally contain roughly about 14 grams of alcohol, but in certain countries it differs, so that's why I put 8 to 14 grams. So it will come as 1 glass of wine, 12 ounces of beer, or 1 shot of whiskey. So if the patient is already having a liver disease, either due to alcohol or something else due to viral hepatitis or hemochromatosis, there is no such safe level of drinking. So any amount would be too much for them. So they should be counseled at the first visit that there is no safe level of drinking for them and they should abstain. The good thing is cessation of alcohol at any point reduces the disease progression. How do you identify harmful use of alcohol? The first question would be, how much do you drink? And the patient would say, I only have 1 drink a day. But their drink may not be the same drink that I would really mean. So it's always better to quantify alcohol in terms of units or grams, even though it is time consuming and difficult to obtain. So for example, when you ask that question, a lot of our Sri Lankan people would say, I don't drink much, but 4 of us would finish a bottle of whiskey a day. So 40% of alcohol means 40 units of alcohol in 1 liter of that alcohol. So in 750 bottles, it will have 30 units. So if it is consumed equally between 4 people, 1 person will have 7.5 units, in other words, 60 grams a day. Good luck with calculating the level of alcohol with illicit alcohol, in other words, kasipu. It's roughly around 22%, but you would never know what the exact alcohol percentage in these beverages. This is the new classification for steatosis liver disease. So as you can see, Patients with metabolic dysfunction may also be consuming alcohol. So if they consume alcohol under the safe level, then they can be considered just as MASLD, or in other words, metabolic dysfunction associated steatotic liver disease patients. But if they consume alcohol more than that of the safe level, which means 30 grams per day for males and 20 grams per day for females, then those patients are in the group of MET-ALD. How do we screen? I often find history from the patient as well as collateral history from spouse, friends, children quite helpful. Audit C is a good questionnaire with a good sensitivity and specificity compared to other screening tools. There are biomarkers available in other countries, but we don't have it here, which can be useful in transplant recipients. The problem in alcohol use disorder screening is, one is the patient underreporting, the other thing is clinician underestimating the alcohol-related problems. So this is the questionnaire I told you about, which asks about the alcohol drinking habits and diagnose alcohol use disorder. What happens in excess alcohol? First, there will be steatosis. Then there will be inflammation, steatohepatitis, and leading to fibrosis and hepatocellular carcinoma. Alcohol is absorbed from the stomach and metabolized in the liver, mainly via alcohol dehydrogenase enzyme. Alcohol is converted to acetaldehyde, and acetaldehyde is converted to acetic acid by acetaldehyde dehydrogenase. In this conversion, there will be less NAD and high NADH, which causes suppression of fatty acid oxidation, increased fatty acid synthesis, and impaired lipoprotein assembly and secretion, which causes accumulation of fat in the hepatocyte. Also, alcohol increases the peripheral catabolism of fat, which increases the circulating pool of fatty acids and steatosis. Excess alcohol leads to excessive production of acetaldehyde. Then they form adducts, chemical adducts and protein adducts. Chemical adducts produces neoantigens, which attach to the surface of the hepatocytes and activates the immune system, causing autoimmune-like reaction and damage to hepatocytes. Protein adducts causes oxidative stress and hepatocyte damage. When there is excess alcohol, acetaldehyde pathway is not enough. So there is induction of CYP2E1 enzyme and generation of reactive oxygen species damaging the hepatocytes. It also impairs methionine metabolism and causes susceptibility of hepatocytes to oxidative stress. Alcohol causes a leaky gut. So more and more bacterial endotoxins will be uptaken, and they will also induce inflammatory response in the liver, leading to inflammation and hepatocyte damage. Fibrosis happens when there is activation of stellate cells due to this inflammation. They will transform into fibrogenic cells, which would secrete collagen 1 and 3 and induce fibrosis. And also, when they get the properties of a myofibroblast, they would constrict the sinusoidal vascular channels and increase vascular resistance, leading to deranged perfusion. So what are the risk factors for developing alcohol-related liver disease? The main risk factor would be the amount of total alcohol use. If a person drinks 60 grams of alcohol for a day for 2 weeks, there is 90 to 95% chance of developing steatosis in that liver, but which is reversible with 4 to 6 weeks of abstinence. Risk of cirrhosis increases with more than 10 years of drinking for 60 grams a day for male and 30 grams a day for females. But only 6 to 41% will develop cirrhosis due to the other risk factors associated with it. So, female gender, smoking, obesity and malnutrition, diabetes, coexisting other liver diseases increase the risk of alcohol-related liver disease. Certain genetics and coffee will reduce the risk of development of liver disease. This is the spectrum of alcohol-related liver disease. With chronic alcohol misuse, 90 to 95% of the livers will get steatosis. And from steatosis, 10 to 35% will develop alcohol-associated steatohepatitis. And from there, 10 to 20% will go into develop cirrhosis, and 3 to 10% will develop hepatocellular carcinoma. So the first stage, alcohol-associated steatosis. Patients would be generally asymptomatic. We can see elevation of AST as well as gamma GT and steatosis on ultrasound scan imaging, which is reversible with abstinence. When they go into cirrhosis, we would be able to see one or more of these physical findings in those patients. The blood investigations, gamma GT, increase of gamma GT is too non-specific, although we normally take it as a marker of alcohol liver disease. There can be obstructive causes which causes increased gamma GT. AST would be more than ALT, usually in the ratio of 2 to 1, and the levels rarely exceed 300 in alcohol-related hepatitis. But any cirrhosis can have AST more than ALT. We can also observe elevated bilirubin, low platelets, low albumin, elevated MCV, and elevated INR. The gold standard imaging technique would be ultrasound scan of the abdomen. Transient elastography can be helpful in identifying early stages of fibrosis, but it's always better to do it after a period of abstinence because falsely elevated levels can be seen when the patient is actively drinking. I have given two case scenarios here, patient A and patient B, both drinking in excessive amounts. So patient A comes to your clinic saying that he's feeling sick, and the blood parameters are shown here. AST 150, ALT 48, gamma GT 200, bilirubin slightly elevated 1.8, INR 1.2, WBC 6000. What do you think this patient is having? Any guesses from the audience? Yes, sir.
The patient, first patient A might be having cirrhosis, whereas patient B might be having alcohol hepatitis.
Yes, sir.
Am I correct?
Yes. I was not expecting that answer from you, though. So I wanted the audience to answer. So we have to recognize this alcohol-related hepatitis because acute mortality is very high. Don't confuse alcoholic steatohepatitis with alcoholic hepatitis. Steatohepatitis is just the histologic diagnosis, whereas alcoholic hepatitis is the clinical diagnosis with fever, jaundice, tachycardia, hepatomegaly, encephalopathy, and in the bloods where you get leukocytosis with neutrophilia and abnormally high bilirubin and INR levels. So I put this slide to show you the alcohol-related hepatitis can occur in any stage of the liver disease. Even in steatotic stage, it can present, and also in cirrhotic stage, it can present. Since this is a clinical diagnosis, I would first tell you about the diagnosis. Onset of jaundice should be within 60 days of heavy alcohol use. What we say as heavy alcohol use is more than 50 grams a day for a minimum of 6 months. And the bilirubin would be more than 3, elevated AST from 50 to 400, AST-ALT ratio of more than 1.5, and there should be no other causes of acute hepatitis. If the patient fit into this criteria, we can say the patient is having probable alcoholic hepatitis. But to say the patient is having definitive alcoholic hepatitis, we have to go for the biopsy, which we don't do routinely. There is another entity called possible alcoholic hepatitis when the clinical diagnosis is uncertain due to other confounding etiology of liver disease. It's the same thing. So liver biopsy. Why should we do the liver biopsy, and is it easy to do? Liver biopsy can be performed when you have a doubt in diagnosing alcohol-related hepatitis. For example, when there are potentially confounding factors like ischemic hepatitis, possible drug-induced liver injury, uncertain alcohol consumption, and presence of atypical lab tests like ANA being positive and anti-smooth muscle antibody being positive. It is useful in staging and prognostication, but transjugular biopsy, which is the safe type of biopsy, is not readily available in Sri Lanka government sector. Patients would be too ill to undergo percutaneous liver biopsy. These are the findings that you would get: macrovascular steatosis, hepatocellular injury with malaritic bodies, ductular reaction, and liver fibrosis, which is called as chicken wire appearance. It is important to assess the severity of alcoholic hepatitis because in severe alcohol-related hepatitis, the mortality at 28 days is 35 to 45%. And it also can be complicated with liver failure, GI bleeding, sepsis, or hepatorenal syndrome. Recurrent alcohol-associated hepatitis is also common and has increased mortality. So these are the prognostic scoring indicators developed so far. The first one to develop was Madrid discriminant function, MELD, and then a big Glasgow alcohol hepatitis score, and Lille. Madrid's discriminant function uses prothrombin time and serum bilirubin. And if it is more than, it's a calculation mainly. If the calculation is more than 32, we call it a severe alcoholic hepatitis, which has very high mortality rate. If it is less severe, if it is less than 32, the mortality rate is less than 10%. But there are a few drawbacks. It does not differentiate severity beyond the score of 32. It doesn't incorporate the change in lab investigations over time, and prothrombin time is variable at different labs. That's why we get INR, but here they use prothrombin time. MELD score, model for end-stage liver disease, it ranges from 40 to 6 to 40. It's the same used for liver transplant. If it is more than 20, we call it severe alcoholic hepatitis. And if there is increase in MELD by more than 2 in the first week, it predicts increased mortality as well, which is called delta MELD. There are a few studies to identify what is better in assessing the severity. And this study shows MELD is better than MDM. So now we use MELD. Lille model. This predicts mortality in those of steroids, those on steroids. It uses age, renal insufficiency, prothrombin time, albumin, bilirubin at day 0 and day 7. Score of more than 0.45 indicates lack of response to steroids, and it predicts 25% of survival at 6 months. It tells us whether to stop steroids at day 7. So this is the same thing. As you can see, at 180 days, only 25% of patients will be surviving if the Lille score is more than 0.45. Evaluation of and management of alcohol-related hepatitis. I know you can't see this, but I got this from American Associated Liver Disease guideline of management of alcohol hepatitis. I have put the references later. So initial evaluation includes history and physical examination and blood investigations like bilirubin, AST, ALT, INR. And then we have to exclude other causes of liver disease like mechanical obstruction, drug-induced liver injury, viral hepatitis, autoimmune hepatitis, or ischemic hepatitis. When we come to a diagnosis of probable alcoholic hepatitis or possible alcohol hepatitis after biopsy, then we have to assess the severity. When we identify uh, alcohol-related hepatitis, and when we identify that it's either probable or definitive, then we have to assess the severity. Then we have to use MEL score. If the MEL score is more than 20, and if there are no contraindications for steroids such as infection, those patients can be given steroids together with N-acetylcysteine. And we have to assess the response at the end of 7 days by Lille score. If the Lille score is favorable, we may continue up until 28 days. If not, we have to stop and refer the patients for early liver transplantation or conservative management. If the MEL score is less than 20, or if the patients have contraindications for steroid therapy, or if the MEL score is too high, let's say more than 50, then again, patients either should be referred for liver transplantation or managed with full other supportive care. So this is quite recent research done in 2021, identifying the therapeutic window for steroid use in severe alcohol-associated hepatitis. And they have given steroids for patients who have MEL score more than 20, and they have found out maximum benefit of steroids was seen in patients with MEL score between 25 to 39, and if MEL score is more than 51, it's futile. The survival benefit was not sustained at 90 or 180 days. It was only the survival at 30 days which was changed by the use of steroids. It's the same thing in a graphic view. You can see in the dark blue area from 25 to 39 MEL, there is a significant benefit of survival. But this is the mortality at 30 days. This is an old trial which was done in 2011, where they checked steroids and pentoxifylline for the treatment of alcoholic hepatitis. In this trial, they used MDF score more than 32. It actually showed some reduction of mortality at 28 days, although it was not statistically significant. There was no effect shown at 90 days or 1 year. Pentoxifylline had no effect on mortality. This is another trial showing the benefit of adding N-acetylcysteine to steroids. When NAC was added, the 1 month mortality was improved, but not at 3 months or 6 months. So other than corticosteroids and N-acetylcysteine, anything else that we can use to improve the survival of these alcohol-related hepatitis patients? One thing would be helping them with the abstinence and nutrition and early liver transplant. How do you help patients to abstain from alcohol? The first thing, it should be individualized. Cognitive behavioral therapy or mutual support groups can be useful. And also, we can use certain medications. Naltrexone, for example, is opioid antagonist, which blunts the high effect of alcohol, which can be given in cirrhotic patients. Another drug would be a compressate, useful. Disulfiram, not so commonly used due to unpleasant reactions if returned to drinking. There are some non-FDA approved treatments like gabapentin, topiramate, baclofen, and varenicline. Several studies highlighted that protein energy malnutrition is almost always there in every patient with severe alcoholic hepatitis, and it is associated with poor prognosis. So they recommend daily energy intake of 35 to 40 kilocalories per kg of body weight and daily protein intake of 1.2 to 1.5 grams of kilogram body weight. Anabolic steroid trial did not alter the mortality. For nutritional therapy, they have tried intensive enteral nutrition in forms of tube feeding in patients receiving prednisolone, but it did not make any difference in mortality. What can we do for alcoholic hepatitis patients if everything fails? Usually, traditionally, 6 months period of abstinence was necessary for transplant listing in alcohol-related cirrhosis. But these patients with alcoholic hepatitis are very sick, so they can't wait 6 months. So early liver transplantation has been shown beneficial. There is a small study where they have selected only 2% of alcoholic hepatitis patients without any prior episodes of alcoholic hepatitis, and with supportive families and voiced commitment to alcohol abstinence, which has showed 6-month survival benefit. This is another study where there had been no sobriety period shown survival benefit at the end of 1 year as well as 3 years. Although there is some sustained alcohol use of 10% at the end of 1 year and 17% at the end of 3 years. So younger age and lack of complete acceptance of alcoholic hepatitis diagnosis were associated with post-ALT recidivism. More than 10 drinks a day at presentation, also associated with post-liver transplant death, and there is a significant decrease in 5-year survival with early alcohol use. So in summary, incidence of alcohol use disorders, alcohol-related liver disease, and alcohol-related hepatitis are increasing, and we need effective screening tools to recognize and treat them. The mortality due to alcohol hepatitis is increasing. We need to recognize the severe form and treat the selected patients with steroids and NAC. Mild to moderate alcoholic hepatitis without hepatic encephalopathy should be monitored only. Alcohol abstinence is the key. Assess for nutritional deficiencies and treat with enteral nutrition therapy. And early liver transplant in alcoholic hepatitis improves survival. These are my references. Any questions and comments?